Welcome to Psych for Psychology, a Nystrom & Associates podcast. Our host, Brett Cushing, is a licensed marriage and family therapist at Nystrom. Each week, he talks about all things mental health and therapy with guests, and you get a chance to dive into specific psychology topics that help promote personal development and wellness. And now, your host, Brett.
Hello and welcome to another episode of Psych for Psychology. We are having special guests today. Today we have Marcy Tatro and we have Jay Paul, and they are coming all the way from Mankato, Minnesota. We're delighted to have you guys here. Thanks so much. Marcy, you lead a radio show with Jay Paul, and it goes by a couple names. What do we call it? The real catchy phrase, the mental health?
Well, mental health show.
The mental health show.
It's morphed into that.
Yes,
like
our
that.
Mental Health with Marcy, the Mental Health Radio Talk Show. We even have a handle on Instagram, so it's MARCY Tatro, Marcy Tatro, and it's Mental Health with Marcy.
Wow. Well, we are delighted to have you here. This is a show you've started, and you're addressing mental health topics, and you are an LICSW, which means absolutely nothing to a lot of people.
Yes.
What it really means is you're a licensed independent clinical social worker.
Yep.
And you work out of Nystrom's Mankato Clinic. And we have Jay Paul, who I understand we could do like a book or a movie on his life.
I'm a court jester.
Yes, or it'd be a comedy, technically.
41 years in radio, so that's all I...
Wow, well, terrific. Yeah, and so we're kind of doing a twofer today. This is on our podcast and going to be on your show as
KTOE,
well.
in Mankato, yeah.
So we're excited to have you here today too, Brett, with us.
Well, thank you. I'm delighted to be here. This is fun and really practical. So today we're going to be talking about and trying to help people understand sort of the on-ramp. When you get into therapy, it can be kind of overwhelming. What do I do? And then we talk about LICSW. Well, I'm an LMFT and I do EMDR. And, we throw all these letters out there and people, all they know is, wow, I'm really having a hard time. And we kind of throw alphabet soup at them and assume they know what we're talking about. And so we thought maybe today we're going to try to help people understand what to expect.
Yep. Well, it takes a lot of courage to take that first step forward. So we talk about that, how at first it's hard to even kind of get yourself to see somebody for therapy because of all the different beliefs that we may have about going to see somebody for our mental health and what does this mean for us? Well, and we've talked about this on the show a lot, that a lot of people struggle. You're not alone. And oftentimes we are our own worst critics and things like that. And so, after you take that first step forward, you can maybe call around to different places like Mayo, Prairie Care. We talk about them quite often at our Nystrom. You call and make an appointment. All right, great. Hoofta. I took that first breath. I made the first leap forward. Now what? Now I'm going to go see a therapist. Jay Paul, you mentioned this before. You've asked me, like, Marcy, what does your office look like? Because it's been a big mystery.
Yeah, I got to visit. I did a little road test out there to the office, and this just looked like any other office building, really. What I like is you guys have you put a premium on confidentiality, so people can just feel comfortable knowing that they're not being told on, citywide that they're going to see a therapist or whatever. And you guys are really therapy is made for the confidentiality of it, and because you're always there to help that person no matter what. And it really shows them that they're not the only one that feels the way they do.
And then this gets into, okay, good, I'm here. Now I'm here for maybe anxiety or depression. There's different things that bring people into the office for therapy. But what do I do now, and what kind of therapy do I do? So these are some of the questions that people have that might be feeling like overwhelming, like where do I go? And you might, when they call and speak with someone on the phone, they might ask you questions like if you want this type of model or EMDR, if you want DBT, and they're like, I don't even know what that is. And then you start getting anxious just because now you're feeling like I don't know what to do.
I think you're right. I think that's what is sort of universal human experience. When we don't understand things, we tend to pull back from it. We can sort of have negative judgments about it. When I'm driving on the road and I see somebody driving, well, typically really slow because I always want to go really fast. And I'm like, why are they going so slow? And then I realize, oh, wow, they're from out of town. It's an older couple. They don't. And then when I understand, I'm much more tolerant. I can kind of absorb it.
Sure.
And before that, I can become intolerant. So I think you hit on a really good point. When people are coming into therapy, there's all these unknowns. And then we throw things at them. Do you want to do this? Do you want to do that? And it's like, oh my God, what are you talking about? And so we're going to try to make it easy for people to understand and sort of have a nice, easy on-ramp into therapy, because it can be really practical and life-changing.
Mm-hmm. I would like to talk about first, let's just do anxiety. Let's say I'm a college student coming in, I have a lot of anxiety, and I'm going to see a therapist for the first time. And what would the process look like? Or maybe what would be a first two sessions look like, Brett?
Yeah, thanks. That's a great one, Marcy, because depression and anxiety are the top 2 reasons people do come in for therapy. Sure. And so typically they would schedule an appointment, just like scheduling with a doctor. And so we get you on the schedule. You come in to typically a waiting room, and it's usually pretty quiet. We'll come out. We'll come get you. There's a strange person. And then you come back into the office, and typically the offices are kind of designed in a way that's comfortable for people.
Is it the standard couch?
I have the standard couch
Not
myself.
every one of those, because
that's just so I can take naps during the day. But I do have one.
They are comfy to have.
Yeah.
So you don't have to kick back to talk to a therapist. You can sit in the chair.
Well, and it's funny. I think of it 2 ways. This is I talk about it like this. When you're coming, think about you're just going to have coffee with somebody,
sure,
at some place. And then what I tell them to what you were referring to earlier, J. Paul, is it's kind of like coming to my office is kind of like going to Vegas. Because the adage there is like, what happens in Vegas stays in Vegas. And I tell my clients, what happens here stays here.
I like that. Yeah.
See, I started thinking about all the glamour and is it like the nice hotel, or what's that one with the Bellagio? Is it like water?
Yeah.
Do you have water stuff in your office?
As far as you know, I do. But no, I actually, it's not that cool.
All right.
But it is a pretty cool experience.
She does decorate her office to her personality.
Well, it's more like the message. So I actually didn't follow the technical professional. This is just a side note. I didn't actually follow the professional advice for how to do a therapy office when you're designing it. It said like you want to have like neutral colors and relaxing colors. And so I'm like, know what? I really want my clients to feel empowered to make changes and to feel this is like a cozy place, but yet elegant, and that they feel special and empowered. And so I went with a nice bright blue, and I picked a couple paintings I love. Mm-hmm. There are some impressionist paintings of Europe, and one's a castle, and there's like bright blue and green and yellow colors, right? But anyways, I had like a glam couch to go with it, and
oh wow,
even the men like my office. So yes, everyone loves my office.
I wouldn't mind going to see it.
Sometimes people do call it the princess office. Not gonna lie, but that's why I joke. Like everyone likes it.
Well, I think we're touching on a good point. We are very intentional in knowing that when people are coming in, it is kind of freaky. And I don't know if you heard this, but I heard years ago, the average number of times people actually come to therapy is like -1 because of all the times people schedule but never make it to the first session.
Actually, I've never heard that before.
Yeah, I've heard it numerous times. I had to keep hearing it to believe it. And so we really understand when people are coming in, this is kind of scary for people. And if you're coming in with anxiety, it can be a little bit anxiety producing. So we try to be very intentional in the office. We let people know basically this, that, hey, what happens here stays here. It's totally confidential unless you're going to hurt yourself or hurt somebody else or someone's going to hurt you. And then we'll talk about that. And we probably have to share that with somebody. And what we want to do for insurance purposes, we have to do something called a diagnostic assessment. And that's a big word of just getting to know you. And we have to come up with a diagnosis that we can submit to insurance. Now, personally, I don't get real hung up on the labels. I think it can be helpful to sort of say, oh, okay, that's kind of the ballpark, but I'm more focused on, all right, so what do you want for yourself? So I think a good therapist is going to ask a client when they're coming in, what do you think you want? What do you think you need? And so with anxiety in particular, we'll do that diagnostic assessment, talk about it with people, get to know your background a little bit. And I tell people this. In part of that diagnostic, I'll ask, I'll say this, I don't need to know specifics. Okay, but just for right now, have you had, in a general sense, any traumas, any sexual abuse, physical abuse, emotional abuse? I'm just looking for a yes or a no. I really want to respect, people's boundaries, that I'm a stranger to them. So when they come in, I have to know something, but I don't even know the details.
Yeah.
And so we want to make it as approachable as possible for them when they're coming in. And then when we do that, like the next session, we might finish that up and start to do a treatment plan. And this is really helpful, I think, for people when you're coming in. Ask yourself, what do I want to get out of this? I love the old adage, if you aim at nothing, you hit it every time.
Yeah.
And so we don't want therapy to be hitting nothing. And so we do want to come up with some concrete goals. What do you want to work on? How do we know when we're going to be where you want to be? So to your point, Marcy, what you were saying is we want to empower our clients. And so I think people coming in, that's helpful to know. And then with anxiety, when we kind of know those goals, we'll start talking about things. And there's different approaches. I think in general, a lot of therapists will start to look at, all right, so what are your thoughts? What are your things that sort of trigger your anxiety? How does it make you feel? And kind of what are the behaviors that go with that? And sort of analyze that. And I'll say this, look for a therapist who has a good balance of validating and always leading with validation, sincere, and having some aspect of change to that too. We don't want therapists that are all about change and don't validate, but we also don't want therapists that are always validating and never any change.
And we've talked about this before too. There's nothing wrong with changing therapists if you're not comfortable with who you are first in with. Nobody's feelings are going to be hurt, on the therapist side.
Right. Thank you, Jim. Yeah.
We've talked about how it's important to have a connection with your therapist, and it's okay if you change. And we all know that. We know like you're not going to fit with everybody, and that's okay.
Have you ever? I know I've had that.
Yep.
Have you had that?
Oh yeah. It's not. Yeah. And that's okay because I know that it's. Some people are more wired for me, and some aren't, and I know I'm more creative and right brained, so
yeah.
I'm very much creative, empowerment, work a lot with military, type of thing. And I also work really well with girls. So I work really well with girls, anxiety, boys with autism, military, women with trauma. So those are like the kind of the groups of people that I work really well with. Or sometimes I'll also do Christian counseling because I also have my MDiv. So I'm trained as a chaplain. So if there's a personality type that has kind of those type of things or struggles, they tend to be a good
And then are there for you as a therapist, as I know there are for me, are there certain areas that you're like, this isn't my wheelhouse, and maybe you'd refer somebody to somebody else?
I think one group I do definitely refer out is more like the Access B. Or it used to be the old Access B.
Right.
Which would be more personality.
Right.
So I treat more, I would say clinical mental health, which is Access 1, which used to be called that. So like more bipolar, depression, mental health. I also treat psychosis and schizophrenia.
I didn't know that.
Yeah.
That's really excellent because psychosis is something I don't work with, and it's not my wheelhouse. And so it's hard to find people who will work with that. So
actually, interesting enough, you might find this interesting. My first clinical training was at the Denver VA, and I was trained in a life skills, which is like an outpatient for persons or veterans with serious persistent mental illness, and they had schizophrenia.
Oh, wow.
So I was actually trained in coping with voices. And then I wrote a psychotherapy for Vietnam veterans for suicide prevention based on Viktor Frankl's work on local therapy.
Oh, wow. We refer to that on the podcast periodically. Yeah. Man's Search for Meaning.
Yeah. We actually just talked about that this morning on our other show. So those are the two things that was really prevalent in my training. And also I did some stuff with the PTSD in the inpatient unit. And then I worked a little bit in the crisis in the ED. So assessing. So I got to follow a really cool colonel around.
Wow.
He was the Air Force colonel.
That colonel got to follow you around. So
well, actually, he did ask me my opinion a couple of times. Like, hey, that's actually very, very observant of you, Marcy. So I had some kudos from the colonel. Yeah.
Kudos from the colonel. I love that. That's good.
It's a good title for a book. No, I'm sorry.
Well, I think we're thinking about people coming in for therapy. We're already highlighting there's lots of different things people could be coming in for. And when we're dealing with anxiety and we're dealing with, like, as you talked, some of those Access 1 type things, the mood disorders, the anxiety, depression, bipolar, it's going to be more of kind of what we refer to typically as talk therapy. And in one sense, it really is like I tell my clients, bring your own beverage, and we'll just, in a sense, hang out just so that it's a relaxed setting. And yet we're going to be talking a lot more deeply about things. And I think a good therapist is going to make sure we're meeting our clients where they are and not getting too far out and pushing them too hard either. And I think that's a concern people have going to therapy is, do I have to, I'm not ready to spill my guts. Perfectly fine. Yeah. I'm a stranger to my clients and kind of strange even to them. And so we will meet people where they are. We're going to be doing a diagnostic assessment. We're going to be doing some treatment plan goals that are kind of specific that are according to the needs and wants of our client. And then we're going to be talking. And it's really a pretty safe environment. I mean, my clients that I meet with regularly, it's a very close relationship. And you and I have both been chaplains too. So I know I've told families when I've gone on a chaplain call to do a death notification or something like that or traumatic, I feel this incredible privilege and honor because you're experiencing with them raw, intense emotion. And that's intimacy. And so these people invite me, this stranger, into the most intimate time of their life. And so I don't know about you, but that was an incredible honor for me and a privilege. And so therapy, I approach it the same way, that when somebody's choosing to come to see me and we're going to hang out, we're going to talk about some tough things, I want my clients to know this is a real privilege for me in all sincerity. And I think they feel that. They know that. And I think I'm not unique to that. I think.
Right. You're very sincere. And I can see that. Like, I know listeners, you can't see Brett's face right now, but he's very sincere. He has really good eye contact and his eyes are soft, which it's like they're very much, you can feel that you care and you're listening and you're genuine. Like you can feel that on.
Oh, thanks.
Yeah.
I'm glad.
Yeah. No. And so I think that's important. And like you said, when I was at the nursing home as a chaplain, it was one of the most humbling and sacred experiences for me. And also I did another CP. Yeah, CP. So I did CPE at a hospital, and that was really difficult because of those times where they do call a chaplain, not the social worker. They call a chaplain in for a time of death or to comfort the family. Yeah. And some of those are the most challenging moments where your heart just breaks. And then they sometimes, when you're first new, you're like, what about some words from the chaplain? You're like, oh boy. And and all eyes look at you and you're just like, oh Lord, please, help me have something to say.
Who am I to be?
Who am I to help? And then sometimes you just say that little prayer, and I'm not kidding, the most beautiful words just sometimes just come right out.
Right. I've had that too. And I'm like, wow, where did that come from? But I'm thankful they came there.
Yeah. And I view therapy and being a social worker very much similar to, I think, the chaplaincy where, and I'm not really outward, but on the radio, I think we can share this now, is that my faith is a big piece of who I am and why I'm at Nystrom, but also why I'm a social worker in general. And, it doesn't come up in therapy all the time, but sometimes if the client brings it up, again, I never press my views on a client, but if it's an open conversation or we talk about spiritual coping or resources, things like that. So it does come up.
That up. Yeah. I think two things that kind of came to mind as I was listening to is like, well, who am I to be able to help somebody? Well, we go through a lot of training, and good therapists are going through their own therapy pretty much on a regular basis. So I like Carl Jung, the old, psychoanalyst at the beginning of the 1900s, talked about the wounded healer. We did a podcast on that once too, and how many therapists, we've gone through our own wounds and healing process. So we do understand. And you mentioned kind of a sacred place. And I think the atmosphere is such that it's a really unique place where people can come into therapy and for maybe the first time in their life experience, I'm not being should on, by other people. I'm not being shunned, shamed, or should on. And I can just be me, fully accepted and really understood on a whole different level. So it is a kind of a sacred, safe place.
And I think the big thing too that you're hitting on is that you're being seen. You're being seen. Like, I see you. I see that it's okay to feel what you are. And it's okay to feel sad about this. It's okay.
How quickly does that transition from fear to see you guys to looking forward to their being with you?
I think it depends on the therapist and the client, honestly. I think it really depends because for example, I took a new training on prolonged exposure therapy, and that is a very intense therapy, but it treats PTSD. So it's the number one trauma treatment, it's the number one PTSD treatment. I know, John Sutherland, you're listening right now. It's the number one PTSD treatment for PTSD. And so prolonged exposure therapy is phenomenal, but there is going to be some anxiety about going to those appointments. But for other types of, and I can just speak for maybe a little bit loosely, I have clients that sometimes, are very, very happy when they leave my office. We're joking, laughing, they're very, very happy. So I would say maybe the majority of my clients are pretty happy. So it's not,
I would say that too.
It's not, I wouldn't say that it's fear-based at all. Not that much, maybe unless there's something troubling or upsetting, oh my gosh, I'm really stressed out about this, or,
I think that happens. Yeah, and not in any way trying to belittle clients. I like those videos where you see the dog that's been on the street neglected.
Yeah.
And people try to go up to them and the dog lashes out.
Sure, yeah.
And then they try to sit with them and give them a little bit of food, and it takes time. But then you see this dog sort of emerge that was never seen before. It's filled with joy, and it's so grateful. I think therapy can be a lot like that. People come in with different levels of trauma history, and some people it's not as deep and severe. So it generally will depend on how people are coming in. And for me, I try to make a connection before somebody leaves on that first session, even if it's connection about sports or something funny, so that people, if there's a connection, they'll realize, okay, I can come back. This wasn't as bad as I thought.
Mm-hmm.
We got 10 minutes left here, and I just want to, that kind of reminded me of Dr. George Kamaritis, who's a legend around here, says, you know how you're a successful therapist? When they come back.
Right.
Mm-hmm.
It's just that simple.
Yeah, no, that's a really good point.
And then I started thinking oh boy, I had 10 cancellations today. What would George say? I didn't have 10, but I was just kind of kidding, right? I'm oh no. And that's where you touched on, who am I to say something? Who am I to give advice, or who am I to be in this position? And I think, honestly, people that I know, at least I can say this for 100% for Nystrom. So I want to speak from fact, experience when I talk on the radio, and I do want to talk to you about that sometime. That the colleagues I know at Nystrom have been nothing but extremely competent and compassionate. And I think there's this element of really a passion and desire to really want to help people, because it means something to them. And it's a very humbling and honoring place to be a part of such an organization where you have so many people and colleagues that have this.
It is. It's inspiring for me, and I love our new mission statement. We really, truly want to empower people to become the best version of themselves. And where else in our culture can people go to, and they know, hey, I'm going to become the best version of myself here.
The military. Be all you can be. We just had a military recruiting thing this morning.
Right.
Yeah. So.
Yeah, but I think in a very holistic manner, therapy is a place where people can get beyond the things that have kept them from being everything they've wanted to be. And so we try to make sure that we have the right environment, we have the right people, we have the right skills and tools. And so I think what's helpful for people to also understand is there's different levels of treatment. So there's talk therapy, which is typically like a level 2, and you're dealing a lot of times with mood disorders, anxiety, depression, things like that, marital problems, partner issues, relational challenges. And then sometimes when people are having more intense trauma per se, or they're having you talked about Axis B, the old, personality disorders of narcissism and BPD, borderline personality disorder. That's like intensive outpatient. It's the step before hospitalization. And then the third step, obviously, is like a hospitalized situation or partial hospitalization.
I was just thinking about, thank you for bringing up the borderline and the different diagnoses. And so if you are coming to the office and you're seeing a therapist for the first time, One question you can always ask the therapist, is just have this on your radar, is like, what are some things you recommend for anxiety? Or if I feel really nervous, what are some like treatments that you recommend for anxiety? Or I'm really struggling with depression. And if they say something like CBT, it's always okay just to ask, oh, well, actually, what is CBT, or what's cognitive behavioral therapy? What is, ACT, acceptance commitment therapy. So it's always okay to ask, what are those acronyms? And, hopefully the therapist can also explain too as well.
I'm so glad you mentioned that, because it is kind of like going to a doctor's office and you sort of get deluged with information. So it's good to empower people with that.
Okay. So we have ACT and we have DBT, which is dialectical behavioral therapy. We have some trauma treatments that are out there, EMDR. I think Nystrom is starting PE, which is prolonged exposure therapy. Again, I mentioned it 3 times, John Sullivan, they will remember. He told us at training that if you mention, I think he said 5 times, if you mention something 5 times, they remember. So PE is great for PTSD only.
That's why on radio we have to run. We suggest they run a lot of commercials, because the repetition is what people remember. If you just run it 1 or 2 times, nobody gets it. It is phenomenon.
It really is. Thing. Yeah. And it's the staple form of treatment within DBT, dialectical behavioral therapy, is that prolonged exposure. So there, I just added it.
Yay!
No extra charge.
Yeah. So I have Brett, I have a burning question over here. So that with your background and your training, do you have like a go-to model that you prefer, or how would you I know, I'm so sorry, it's a hard question.
Well, it's a great
how would you describe your approach, or and maybe if there's a model or two that you follow that you love?
I really enjoy within dialectical behavior therapy, we do something called behavior chains. And so with that, I have a whiteboard, and people come in and they say, oh, I did this behavior again. I can't believe it. Oh, I'm so stupid and whatever. And they beat themselves up. I say, well, let's take a look at it. And I just chart out for them, like, so let's look at some of your vulnerabilities: low sleep, stressed, hungry, angry, lonely, tired. Like, oh, yeah, that going on. And then like, there was some triggering event that sort of prompted this. That was maybe the first domino that fell. And then we look at, all right, what were your thoughts? What were your feelings? What were your urges? And by the time I kind of have all this up on the board with them, I've had people cry, actually, when they look at that, and they can actually say, wow, it really makes sense that I did what I did.
Yeah.
And it's so validating. And again, we talk about leading with validation. So once people can validate and say, hey, that makes sense, now we can start to move on towards some change. So I try to use that in some shape or form in therapy with people, just because it's a great starting point.
It's interesting, because it's like you kind of like having your theory. Do you think that's from your seminary experience, where you like to have a theory that kind of informs what people are doing and why?
I do have lots of theories, and I do try to tailor it, though, to people coming in. I really don't want to have this one-size-fits-all. Behavior is way too complex, and so are we as people. So I do try to look at where people are, and I really kind of lean towards understanding what are what we call cognitive distortions, like my beliefs that just I feel like I have to hold on to, that I've been operating by, that just don't work. And if I can change the way I think, I'm going to change the way I feel, and I'm going to change the way I behave. So I like to look at that, but really look at, people's personality and what they're coming with and what their motivation level is.
Okay. Well, that's awesome. I think that's great.
How about you, Marcy?
What's my clinical style?
Yeah.
I know I'm going to get harped on for this, but
is it PE?
Actually, I think that's my new one. But only if you have PTSD. Again, folks, that's 5 times. Thank you, John. I think I'm old school. I think I'm more Jungian and Carl Rogers, and which is interesting because Dr. George, he's 88, 84, 85.
It's up right there.
He met Carl Rogers.
Oh, really?
Yeah, you should listen to that one. It's a great episode. Oh, totally great.
That would be fun.
But I think I'm back old school, humanistic, unconditional positive regard.
Right.
I'm big on encouraging and empowering. So I think I might have a little bit of like an empowerment coach in me. So maybe a little bit of flair of maybe just pure Marcy, and I just kind of really listen to people and try to be really present. But I've been finding myself going more mind-body connection.
I think that's where our field is going to be going.
I think it is. And I've been finding, I had a health journey last year, but anyways, that's kind of what got me there.
That's another good show we had.
Yeah. But listening to your body and just the difference that it makes when you actually listen. And I don't know if that's an inner voice, God, I don't know what you want to call it, but when you listen to your body, what you need, I'm not kidding. I've felt 100 times better.
Right.
So,
It's like our body is that dashboard, like on our car to tell us what's going on. But we're so busy that we're so accustomed to just go, go, go. We don't really pay attention. That's a powerful point.
Yeah. So I've been doing more mindfulness and then the empowerment piece. And then I'm hoping to do more PE. So in addition, but not in the same sessions. So that's kind of the direction I think I'm heading. And you never know where my adventure takes me, Brett. So maybe someday I'll be like, hey, I'm doing this now.
Well, if you are, we got to talk about it then.
Yeah, I would love to.
Our half hour is up, but we got to have you back.
I'd love to come back. This is a lot of fun.
We got to be back. We got to get together.
We got to get together. Yeah.
I would love that.
Great.
All right.
Thanks for having me.
Yes, thank you for coming. Thanks for having us on your show.
Thank you as always for listening, and please be sure to leave us a review. While this podcast can't be a replacement for therapy, we hope you enjoyed our discussion today and join us again next time. Nystrom & Associates is always available to those who are struggling. If you find yourself in need of support and help, please check us out at nystromcounseling.com.